Welcome everybody. I am Dr. Sashank Joshi. You are watching the 555th show, 555 non-stop edition of Dr. KK's Med Talks. Let's have the headlines for the day. So let's look at the headlines for today. As we talk today, Delhi, Mumbai are reporting, probably they are around their peak of Omicron, and they are reporting a plateau or a small decline. But numbers and test positivity rate is not what we are going by. We are going by hospitalizations, the need for oxygen, the need for ventilators, and the death rate. As we talk, the NTAGI chairman Dr. N.K. Arora said that COVID vaccination program for 12 to 14 years group is likely to begin by February end, and nearly 3.5 crore children in the age group between 15 to 18 would have received their first dose by then. Over 50 lakh healthcare and frontline workers have already taken the precautionary dose as we talk. Clearly, there is a small declining trend with the changing guidelines. We clearly know that we are now treating a syndromic symptom-based triaging approach. And you can see that first time in the last 5 days, we are seeing cases reported today below 2.5 lakhs. And in the last 24 hours, India has reported 2.38 lakhs. Clearly, we can see that Japan has recorded one of its highest COVID spikes. They reported 26,000 cases. This is first time after their Olympic record in August, where they had 25,992 cases. The US Surgeon General has cautioned that Omicron surge in the country has not peaked nationwide, and it could be still few weeks, which will be very tough. According to the Johns Hopkins University data, in the US, they are predicting more than 750,000 new cases on an average, which will be reported every day last week. So today's topic is very pertinent. We have winter times across India. There are fluctuating temperatures, and we are going to discuss fever in COVID times, whether it is due to COVID or with COVID. And for that, we have with us, as usual, our Dr. Rahul Pandit. We all know Dr. Rahul Pandit is a world famous critical care specialist. He works out of Mumbai and Australia. He is an intensivist par excellence and a critical care expert. He is the chief of and director of the Fortis Critical Care Unit and the group, Fortis Group in Mumbai. He is very active on our Maharashtra COVID task force as well as the Supreme Court nominated task force at the India level. So let us look at the topic for the day and let us welcome Dr. Rahul Pandit. Dr. Pandit, how do you see
Good evening, sir.
the current wave? How do you see the current wave of Omicron before we go to the topic of the day?
So Professor Joshi, Padma Award recipient, more than 650 publications across spectrum with, of course, he's a renowned endocrinologist. So that's his main line of publication into endocrine, diet, metabolics, and HIV. I have a real pleasure and honor that I share the screen with him all the time. And I always feel that he gets the first chance to introduce me, and it should be the other way around. But anyways, next time I'll try and beat him up. I'll try and open up the show and introduce him first. So, sir, I think coming to your question, we all know that the wave started with multiple clusters. So it started with the metropolitan cities, Bombay, Delhi, Kolkata, Bangalore, and then it's now spread to the other metropolitan cities plus tier 2 and tier 3 cities. So the metropolitan cities, the big ones which started off first from the mid of December, 20th of December, seem to have hit some sort of a plateau at least. So that's a good way of thinking it. But if you look at the throughout journey in the last 4 weeks, 20th December to say we are now on 18th of January, just approximately 28 days or so, 29 days or so, 4 weeks, we see that the hospitalization has remained low. We see that oxygen bed occupancy has remained low. And we also see that patients who are seeking medical help, many of them are getting admitted, but not all of them are on oxygen, which is actually completely in contrast to Delta. What we saw, Delta wave was predominantly about oxygen and oxygen only. However, I would like to caution everyone and say that yes, it looks like it has plateaued at least in Mumbai and Delhi, but these are just early trends. We still need to know a lot of things about this pandemic, and one of the things which I would like to talk about is that while we have seen a plateau, we always know that within a span of 3 to 5 weeks, sometimes the patients start getting admitted into the hospital at the delayed presentation, second week, third week, fourth week presentation. So I think we need to keep an eye on that. Second is the pediatric population, whatever children have got infected. We also know that around 3 to 4 weeks post their infection, some of them are at a risk of having MISC. So we need to keep an eye on that. And most importantly, have all sections of the society, right from the cream to the people who live into shanties, have all people experienced a similar form of a surge in the positivity, or is the positivity essentially remaining into people who had history of travel and came in contact with people of history of travel? I think that question has not been completely answered yet. So we need to keep another 2 or 3 weeks very, very closely observant before we make a claim that this wave is now declining completely. This is one of the things which I would like to highlight, and this was discussed yesterday by Professor Joshi himself. And we all have to be very clear that the cricket, there is a saying that it's not over until the last ball is bowled. So it's not over in the pandemic until the pandemic is over and we declare it as an endemic. So we should not have any speculations. But yes, the trends are pretty good, sir.
That's very reassuring. And before we go and take a lot of questions from a lot of people on home isolation, blood test to be done, difference between Omicron and the Delta variant, let us look at the topic for the day. See, we are in winter time. If you could have the slides, and fever is a very common thing, and fever is the main thing in the third wave, which we need to focus on. If you have COVID positivity with fever, it is a red alert. If it is particularly fever with more than 100 or 101 or 102 for more than 2 to 3 days, it is an indication to either start medications or get a patient into the hospital. So let us quickly look at fever in COVID times. Next slide. So what is this fever? Fever is nothing but a undifferentiated or acute febrile illness. It's a large, broad-based term, which we see infections in our countries like India, tropical and subtropical countries. And usually, whenever it is of short duration, less than 2 weeks, then we look at usually this mild form is self-limiting, but it could also be life-threatening. And the common causes of acute undifferentiated fevers are dengue, chikungunya, malaria, enteric fever or typhoid, scrub typhus, leptospirosis, Zika or KFD. And the latest addition to this list is COVID. So in COVID time, if there is fever, always rule out COVID. And if COVID is negative, keep doing the test again and again. So that's the first thing. And do not forget history taking. So can it be chikungunya? Can it be dengue? Can it be malaria? Can it be typhoid? Don't forget that. Okay, it may be unlikely, but don't forget that. Next slide. So clearly we know that there is a seasonal variation. For example, mosquito-borne is dengue, chikungunya, malaria and Zika. And these are seen in the monsoon season. Or it could be tick like Cassandra forest disease or louse brown, which is scrub typhus, which is seen post-monsoon. And many tropical areas, including India, malaria occurs round the year. Then there are waterborne illnesses like leptospirosis and typhoid or enteric fever, which are seen throughout the year. But spike is seen in the monsoon season. And seasonal dynamics of enteric fever or typhoid are variable. But usually the peak is observed after rainfall in the northern hemisphere. Scrub typhus is come back now. It's a zoonotic disease. We know many parts of India, particularly sub-Saharan belt from Jammu to Nagaland, there are a lot of outbreaks during the rainy season. And South India also outbreaks occur in the cooler months of the year. So this is the time when never forget the louse brown scrub typhus. We also get a lot of respiratory viral infections, including influenza, H1N1, flu-like syndrome, common cold, and of course COVID during winter season. But whether this SARS-CoV-2 will become seasonal and endemic and circulate year-round is the big question. We are hoping that the Omicron will be the chain breaker, which will make the epidemic of SARS-CoV-2 into an endemic stone, and COVID will have a permanent place in this fever algorithm. Next slide. So obviously, we know that it is the environmental and the weather which impacts the virus and the host behavior and physiology. So we know that there are different types of viruses. Some of them have envelopes and some of them have no envelopes. Now, influenza and RSV tend to be more seasonal, respiratory syncytial virus, and they clearly prefer colder temperatures. So if you look at Delhi-like region or North India, you have a lot of flu or influenza, and we can also have a lot of RSV. And the lower temperatures, what they do is they see the virus has an envelope, which is fat envelope, which is like a lipid ordering the viral envelope. And that improves the influenza virus stability. So besides their effect on stability, the lower temperature and relative humidity enhances aerosol transmission. So these are all airborne viruses. So remember, COVID is not the only airborne virus. In this season, you can have influenza-like flu, you can have a respiratory syncytial virus, and that also has to be ruled out. And it's basically these have all these lipid envelopes. Next slide. So obviously what happens is when the temperature drops, there is humidity, the air changes rate, and the sunlight has dropped down, and the host defense, basically the upper airways, the replication conflict, and the nasal and the bronchial mucosa, what happens is these droplets drop into the airways, upper airways, nose, throat, and basically we know Omicron is a throat and nose COVID, just like influenza is or common cold is. And these droplets, droplet size and matrix, they get into the upper airways and they get sprayed, and then obviously you get the infection. And whether you are, where can you get it? It could be a closed space or a closed environment, and that is where it happens. And of course then when there are schools, there are holidays, we don't apply proper hygiene, and if then the host immune response is poor, then obviously this will increase more. Next slide. So you can see that different times of the year, there is a different type of virus which prevails. For example, November, December, Jan, it's influenza and SARS-CoV-2 and respiratory syncytial virus. Adenovirus is seen across the time. Adenovirus is seen across the time. Then we have different types of para-influenza viruses or human metapneumoviruses, which we'll ask Rahul, or rhinoviruses, which are seen across the time. And some of the non-viruses are seen in summer. So there are winter viruses, all the year viruses, and summer viruses. Which are the winter viruses? Well, COVID is one of them, but COVID is probably going to be all year around. Then we have the influenza virus and probably the respiratory syncytial virus. But remember, the adenovirus, the human Boca virus, the para-influenza virus, the human metapneumovirus, rhinovirus are seen all over the year. And the non-rhinoviruses are seen in summers. Next slide. So clearly we know that high temperature clearly will have a challenge, and it will impair the virus specific adaptive immunity. And when the temperature comes down, then the body's ability to make interferon to clear the virus, that comes down when the humidity is impacted. So remember, whenever the temperature drops and the humidity of the inhaled air has been directly supposed to come at the airway mucosal surface, and this is a huge challenge which we see, and that is why in the winter time you are more susceptible to get all these viral infections. Next slide. So obviously when we get fever, we have to distinguish it. Is it localized in the respiratory tract? Is it localized in the gut or the gastrointestinal? Is there a diarrhea? Is it a urinary viral infection? Usually not. And then is it malaria or non-malarial? And if it is non-malarial, then is it viral? Is it dengue, chikungunya, Zika, or Japanese encephalitis, which is arboviral? Is it influenza? Is it bacterial like a typhoid? Is it zoonotic like leptospira, rickettsia, spirochetal? Or is it amoebiasis? So all these viruses can come. So remember that there is a lot of these things which are there, because this is something which we recognize, and we remember that we need to recognize all this, and we need to identify it. So a doctor has to sort all this out. Next slide. So the main thing which happens is there are so many symptoms. We have to differentiate it, like fever, cough, rash, gastrointestinal symptoms, jaundice, conjunctival suffusion, or in the eyes, they become bloodshot or red. Then the lymph nodes are enlarged, the liver and spleen is enlarged. So usually let us look at COVID, because COVID is common now. And COVID, there is fever for sure. There is cough. The Delta had dry cough predominantly. Now sometimes we get occasional wet cough. There is some amount of rash, but that is very rare in COVID. And gut symptoms are also rare. Jaundice is also rare. In Omicron, there is no lack of taste or smell, but in Delta, the lack of smell and taste is there. Usually in dengue, you will get gut symptoms and conjunctival effusion and lymph nodes. And in other viruses, you will get other challenges. Next slide. So also in the COVID, what happens? The CRP usually goes up. There could be a blood count which can be low, and that is what happens quite often. While in the other viral fevers, we need to do a simple CBC and CRP. If the CBC shows that the red cell width is high, there is leukopenia, that is WBCs are low or WBCs are high, we can differentiate many of these fevers. Next slide. And then based on that, we start testing what we should do. So if we are suspecting COVID, then we do an antigen test. Nowadays, we recognize that do a home antigen test. If it is positive, isolate at home and contact your doctor. And if the antigen test is negative, then stay isolated, but still contact your doctor and rule out other causes. And those other causes need to be sorted, which I alluded to. Next slide. So obviously, I don't want to go into these detailed charts and algorithms of fever charting. We will go as we go by, but your doctor has to sort this out. Next slide. And then, it is very difficult to distinguish them. For example, there are fevers with dengue which has rash, and in dark skinned individuals it's difficult to differentiate rash. In scrub typhus, you get sometimes an eschar, which can also be seen in COVID recognized. Most people have conjunctival effusion, which is not reported in COVID. So often in COVID times, you have to differentiate and rule out chikungunya, Zika, and other viral flus. And which is why there is a need to connect with your doctor colleagues. So please stay connected with a doctor so that they can recognize you, preferably a physician, preferably an infectious disease physician, so that they can do the sorting. Whenever you get fever, it's a red flag. Remember that. That's the first take-home message for today. Next slide. Obviously, the fevers need sorting, and there can be a lot of co-infections. So you can also get COVID with malaria, COVID with dengue, COVID with influenza. So all these permutation combinations also can be there. Next slide. So the commonest way to distinguish flu, cold, and COVID. So COVID symptoms range from mild to severe. Flu is rapid onset of symptoms, and cold is gradual onset of symptoms. Aches and pains are seen sometimes in COVID, but in Omicron they are very common. Flu also they are very common. Cold also they are very common. Cough is seen usually in flu and COVID, but not in cold. Diarrhea is sometimes seen in COVID and flu, but not seen in cold. Fatigue is very common in Omicron and flu, but not commonly seen in cold. Fever or chills are common with mainly flu and COVID, but not in cold. Headaches are quite common in Omicron and flu, but rare in cold. Nausea and vomiting is not seen very commonly, with either COVID or with cold, but more common with flu. And headaches, now in Omicron we get headaches, so the Omicron is very similar to flu. And then runny and stuffy nose is not very common in flu, but can be seen in Omicron. Shortness of breath is a red flag. That is not seen in flu and cold, so that is a big red flag. Sneezing is common in cold. Sneezing rarely seen in Omicron. Sore throat is the main sine qua non. In fact, if I have to distinguish Omicron, it is a nose and throat COVID, and it does not have taste and lack of taste and smell. Next slide. So flu and COVID are difficult to distinguish. And distinguishing influenza and COVID are very important because remember, influenza can recover, but COVID can sometimes cause a fatality. Next slide. Sometimes there could be a flurona, which is a combination of flu and COVID, but that's very rare. Okay, all you need to do is just hand washing, wearing a face mask, distancing. Israel, USA have tested both seasonal influenza and COVID in this season, and you just need to treat them properly. So there is a twindemic, as they call it, of flu and COVID. Next slide. And dengue and COVID is not unusual, but in the monsoons we have seen it. And you have to monitor platelets more commonly. We have to look at fever, headache, and body pain. So you can still get an occasional dengue. And sometimes we might recognize that we don't have to give low molecular heparin, particularly in a dengue patient. So the doctor has to be constantly consulted. Next slide. So if there are breathing problems, cough, headache, loss of taste, then COVID and Delta comes right up on the cards. So what are the warning signs for COVID? Difficulty in breathing, persistent pain or pressure on the chest, new confusion, inability to wake or stay awake, or bluish lips on the face. If these are seen, please go to the hospital and get admitted. In dengue, what we see, if there is persistent vomiting, mucosal bleeding, difficulty in breathing, lethargy and restlessness, blood pressure is dropping down, liver is enlarged, hematocrit is going up, it could be dengue. And both can be seen. Dengue is now less common now, because now January, February, when it comes, dengue goes low on the cards, COVID goes high on the cards, but you can occasionally miss it. Next slide. Then sometimes you remember in COVID times, you can get a false positive Vidal test for typhoid. It's very, very common. In fact, in the good old days, I used to pick up COVID just by seeing a false positive COVID test. And typhoid and dengue false positive tests can be interpreted in quotient during the COVID time. So, you have to take them with a pinch of salt, but leave it to your doctor then. Next slide. There is a role for doxycycline, but not in COVID. So remember, in COVID, there is no role for doxycycline. It is a research tool in COVID, but in non-COVID fevers, doxycycline can have a role. So if you're suspecting there's an underlying infection, then there may be a role for doxycycline. Next slide. So, it's a very old antibiotic. It has a broad spectrum, gram-positive, gram-negative, atypical bacteria. Next slide. It's anti-inflammatory, it's immunomodulatory. It is a bactericidal and antibiotic. And usually, 200 mg once or twice a day can be given. Next slide. It's a very safe antibiotic, a very old antibiotic. And it has a low antibacterial resistance potential. So it doesn't cause a lot of resistance, which is a fear which we have when we use rational antimicrobial therapy. Next slide. And therefore, if you are suspecting somebody with fever or pyrexia, and the fever is constantly up with cytokine upward displacement, and there is a dysregulation of the hypothalamic thermoregulatory symptom, that is something which we know that this is called as a pyrogenic entity of fever. Next slide. So sometimes, doxycycline has been used empirically as a treatment of fever, mainly when we are suspecting dengue, typhoid, malaria, chikungunya, scrub typhus, rickettsial fever, Japanese encephalitis, leptospirosis, respiratory tract infections, or sexually transmitted infections. So when we have all these pyrogens or cytokines, which are made by the microorganisms or direct products or toxins, many a times doxycycline has been used. So in the non-COVID space, doxycycline has a clear role because it is broad spectrum, and even many of the governmental programs have doxycycline because it is cheap and effective. Next slide. So obviously the doxycycline can lower the cytokines also. There is some, and it's well tolerated in undifferentiated fever. So sometimes that is given. Next slide. Can be used also in brucellosis, etc. And also has been useful in dengue-like fever. Next slide. And has been also having a role in the dengue hemorrhagic fever. Next slide. And has some benefit in reducing pro-inflammatory cytokines. Next slide. And has some role in upper respiratory infections, in atypical mycoplasma, chlamydia, legionella, coxiella, which are atypical. So it's inexpensive, easy, reliable, old antimicrobial therapy. Next slide. We can stop sharing the slide, I think. So remember 2-3 things. One thing is that when you're suspecting fever, you must contact your doctor. And if the fever is persistent, it may be the need to go for admission. And if the COVID test is negative, then you might need underlying treatment, either with a drug like doxycycline or some other antimicrobial, based on the observation we see. So Rahul, I have 2-3 questions for you. You
Sure,
are
sir.
working in a hospitalized setup. So I want to ask you, which are the fevers which merit hospitalization? When a patient with fever should rush to a hospital? And which are the fevers where from a hospital we have to shift them to an ICU?
So I think it's a very important question, sir. So one needs to realize that fever often is a message given out by the body that something is wrong. Fever per se is also a defensive mechanism of the body. So it is something which the body is trying to defend. So not every fever we have to worry about, because the body sort of has got a very good natural healing capacity, and it will heal out quite well in majority of the cases. However, when you have these pathogens, viruses, malaria, parasites, that means, or you have bacterial infections, you need to realize that there are some times you need to just go to a hospital. But most important thing is that you need to be in touch with your general practitioner or your family physician. They will be able to appropriately guide you when to come to a hospital. Some of the red flags for the hospital are when your platelet counts or your white cell counts start to drop down quite significantly. That's one of the commonest reasons why patients come to a hospital with just a complaint of fever. And as we know, majority of the viral infections will actually cause that. The viral infections will cause your platelet count to go down, will cause your white cell count to go down, sometimes even taking weeks for it to days for it to come up to a baseline level. Second and most important thing is that if you actually realize that you have some sort of an organ dysfunction, so what does that mean? Suddenly your urine output drops down, or you start to feel short of breath, or your oxygen level. Nowadays with COVID-19, people are very, very cognizant of the fact that they need to check their oxygen saturation. Most houses have got a pulse oximeter now. So if your oxygen saturation goes below 93%, or if you start feeling a little lightheaded, if you're very, very weak, not able to walk and do your own chores at the house, I think these are the times when you need to go to a hospital and get yourself checked and perhaps admitted. Now, which are the patients which go to a ICU? Sometimes patients are taken to ICU for organ support. Sometimes they are taken to ICU for observation. Now, which are the ones which are taken for observations? Are the ones where your platelet count, for example, or white cell count, for example, has gone down significantly. And we know that in majority of the cases, it will gradually pick up. But to keep a close eye on these patients, sometimes we take them to the ICU so that we can pick up a critical drop. A critical drop means platelet count below 10,000, for example, or neutrophil count below 500, for example. And we can take appropriate preventive actions by either giving platelets or isolating these patients who have got a very low platelet count, low neutrophil count, so that we can take a preventive action to help them worsen from the problem. The other patients, of course, are the ones who require oxygen, the ones who require BiPAP, ones who require blood pressure support. Viral myocarditis is a big problem. So people who come in with non-specific chest pain, ECG changes suggestive of myocarditis. And these are the patients who require to come to a ICU for support. So somebody who requires organ support or somebody who requires to be observed closely are the ones who need either hospital or intensive care unit. Let's take up some of the rapid fire questions while we are waiting for Dr. Joshi to join. Dr. Joshi is here. So, Dr. Joshi, I think 2-3 rapid fire questions for you. One is, can we eat non-veg during COVID-19? And then Rinki Soni ji is asking, my daughter is about 13 and gave her vaccine 13 days back, but she got fever today. So around 2 weeks post vaccination, she's got fever. She's given paracetamol. There is a little bit of headache and scratchy throat, itchy throat. What do you infer from this? Rinki
So the
Sahani ji is asking this.
second part is very clear. It is probably a sore throat, probably Omicron, and that needs a symptomatic treatment. See, remember, most Omicron needs symptomatic treatment. Your question on non-vegetarian food is that we are occasional non-vegetarians, but remember that whenever you have an infection, whether it is COVID or non-COVID, have processed food and don't have non-processed foods, because you can then pick up another bug. So the idea is that if you want to have an egg white, which is a good source of protein, you want to have regular, well-cooked fish or a curry of fish or a chicken breast, that is good enough. Red meat, I would say right now you red flag it during the acute viral syndrome. But maybe after a week, you can have a soup of a paya soup or something. That's no problem at all. See, non-vegetarian is a very good source of protein. And in wound healing, it is very important. Similarly, in healing, in general, also in convalescence is very good. So it is not prohibited at all. So that's a myth. In fact, you should be moderating a lot of outside food or fried and fast food. That is far more harmful and deleterious to health. And do not have things which will aggravate your sore throat. So that is something which is
Yes.
very important to recognize, because that will actually cause a lot of hazard shifts. So that is what I would like to answer. So
So
Rahulji, I have
Seema ji is asking.
yeah.
Okay.
Go ahead.
Okay,
Yeah,
you can
you go ahead.
ask.
No, you ask.
Seema ji is asking one question. How many days in quarantine period at home isolation now? And how long are the affected people to be considered as spreaders? I think this is a very important question for especially for Omicron.
So technically, Government of India said that if after 7 days, if you are asymptomatic, then you can actually, if even without a test, with double masking, you can move out. But that is a caveat to that. So I would say that if you are asymptomatic and no fever for 3 days, then probably you are good to go. But I would always do at least a rapid antigen test. I don't want to burden the system with RT-PCR. RT-PCR can be falsely positive also because it will shed dead virus. But if you can take rest at home for 10 to 12 days, it is ideal, because virus can continue shedding up to 10 to 12 days. And therefore, at least if you want to know the contagiousness, at least do a rapid antigen test. and that is something which we can do. And if you have to go because you are a daily wage earner, you're a frontline worker, and it is compelling, then please ensure that you're double masked and do not eat in a crowd. Eat alone, eat at home, and do not eat in the crowd because you could still be contagious, shedding the virus. If your rapid antigen is negative, you're unlikely to shed the virus. If you are symptomatic, however, I would say go by the old 17-day protocol. And also remember that this is a protocol for Omicron. The old Delta is still very much prevalent. And the old Delta cycle time was 14 to 17 days. But by and large, the actively multiplying virus occurs for 10 days. The data on Omicron is not clear. So this is basically based on more of going back into work for asymptomatic people. So these recommendations of isolation are mainly for people who are totally asymptomatic. We have a lot of people who have tested positive and do not have a single symptom, Rahulji. And in them, yes, after 7 days, if rapid antigen is negative, they can go back to work. And if they cannot do it, just go back with double mask. So assume that everybody around you is positive and assume that you have to mask all the time. That is going to be the dictum in the next month or two. That is the way we have to handle this. So Rahulji, two quick questions for you. Gaurav Das is asking that a woman with 52 years with one small kidney, 12% working, another kidney, and this, and also as a pacemaker and high BP controlled, can she take molnupiravir? That's one. And the second question is Ashwin Swaminathan is asking, Dad is rat positive. Fever is around 99.3. It comes once in 12 hours. CRP, D-dimer, NLR is okay. And everything else seems to be okay. So what do we do?
Okay. So I think Gaurav Das ji, the age group which you mentioned, 52-year-old lady, certainly the use of molnupiravir is probably the most appropriate in people who are above 50 or 60 years of age. So that we avoid people who are in the childbearing age group, we avoid couples in the childbearing age group, and of course we avoid children below 18 years of age. What I would say and what we have all agreed upon is that the role of molnupiravir is in exactly patients who are elderly, who have one or two comorbidities. So she fulfills both the things. But we need to wait for at least 48 hours to see whether the symptoms are actually worsening or they are settling. Because in majority of the cases, the symptoms would settle down and you would probably not need molnupiravir at all. So if symptoms keep on worsening, if fever keeps on unabatingly high, more than 100.5 degrees Fahrenheit for at least 48 hours, or your symptoms are adding up, like cough is there, you may have a runny nose and the symptoms don't seem to be going down, yes, third day at least you can start the molnupiravir if required. But be cautious, it's not something which we give upfront. We always wait for the symptoms to worsen. That's the first thing. Second thing for Ashwin ji, it looks like your dad has got low grade fever. It's not very high grade fever, 99 less than 99.5 degrees Fahrenheit. Your NLR is slightly on the higher side, but not too bad. I would just wait for a few more days. I think your dad should be fine. I would just take some supportive care in form of paracetamol tablets, plenty of hydration, good night's sleep, a balanced diet, and just wait out for a couple of days. I would repeat a CBC, CRP, and D-dimer in 2 to 3 days' time just to make sure things are all right. I think this would be the 2 or 3 things which I would like to say. I think, sir, there are 2 questions. One Ritika Jain is asking, and one Pradyuman Satav is asking. Ritika Jain is asking that there is a sudden downfall in cases in Delhi. Is it due to home testing? And Dr. Pradyuman Satav is saying, I had fever for 2 days, dry cough, headache, sore throat, CRP 7.1, beg your pardon, SpO2 99. I took booster dose. My antibody is 24. What should I do?
So I think, the predominant treatment, and we should not do specific treatments here on remote control, is symptomatic treatment. So if there is persistent fever, you need paracetamol. You need to do a proper throat gargle, either with iodine-based gargle or benzodiazepine-based gargles. Sometimes you need to give them a antacid so that their throat is healed faster. Sometimes we occasionally give them some vitamin C and vitamin D as a supportive medicine, and some hot water, etc. So fundamentally, the treatment is paracetamol. If the person is breathless and has underlying history of asthma, sometimes we give a inhaled budesonide. That's where the treatment stops. If there's some suspicion of underlying infection, you can give a drug like doxycycline or something. But Then if the person is deteriorating with persistent fever, persistent pain, persistent chest pain, desaturation with pulse oximeter, then the person needs to go to hospital and see somebody like Dr. Rahul and get investigated. The only test we recommend, and we don't recommend them in everybody, but if there are persistent symptoms, then do a CBC, CRP, which Dr. Agarwal was he's the one who popularized CRP across the world. And CBC, CRP, occasionally we do D-dimer and creatinine. These are the 4 tests which we do. We don't have to do everything, all the tests. And then, do these tests every 4 to 5 days under a medical connect. So my suggestion is there is no broad spectrum treatment. The treatment is predominantly symptomatic with paracetamol. But in the high risk groups, as you rightly said, Dr. Rahul, above 50, two comorbidities, persistent fever for more than 48 hours, one may make a case for molnupiravir at home. And if they go to the hospital, then they can get remdesivir. The only thing which I want to warn everybody is that you could still, at least in North India, this may not happen, but this happens at least in Western India or in Southern India, like a Mumbai or a Chennai or a Pune, where you can miss a delta. And if there could be a lung involvement. So if you are missing a delta, then it's important to recognize that a delta will just behave and land up in ICU with Dr. Rahul. And that's what we want to prevent. So do not miss that delta. That is number one. And the second thing which we need to be very, very mindful of is that you can still have co-infections, secondary infections. So every life is precious and every fever has to be addressed with some degree of seriousness. Most people think it's a mild disease and they dismiss it off as a mild disease. Remember, all Omicron is a less severe disease than Delta. It doesn't mean that it is a mild disease. Most people are asymptomatic. Most people will recover. Yes, those statements are very true. But for a given case, if you have so many comorbidities, then it is very, very essential that you monitor the people properly and appropriately treat them. So that's the main thing. So Rahulji, two last questions, and probably we could wind up then. First
Yeah.
thing is that inside the ICU, it's a different microbial zone. It's a sterile zone, but it's a microbial zone. Inside the ICU, also sometimes you get fever. So, what are those common causes of those fevers? And they are difficult to treat sometimes. And the second thing is that when a person is gone home from the hospital and again starts getting fever, and the fever doesn't come down, how does one approach it?
Yes, sir. So, fever in ICU, when it happens after the patient has settled down from his initial problem, one needs to always make sure that we need to look at the causes for a nosocomial infection. A nosocomial infection means an infection which a person may have caught while they are in the hospital. It's not necessarily a hospital based infection where the bug is just coming because they are in the hospital, but because these patients are so sick, they have got catheters, they have got central lines, they have got arterial lines, they're on ventilator. All the natural barriers which the God has given us, the skin being the most important one, are breached, and you see that microorganisms start to get entry point into the body, and that's how the nosocomial infections can happen at times. We need to be aware that you need to rule out these nosocomial infections. Majority of the times we are aware of what antimicrobial flora is growing on in the ICU, and we start empiric treatment after taking appropriate cultures. There are a lot of the times where the fever is non-infectious as well. So you may have a drug fever, you may have a fever because the patient has got all these devices in there, and you just take out the central line or the arterial line or catheter, and the fever just disappears. You may also have sometimes fever because of DVT or clots, what we call as. There are a number of causes for fever as such. It's not one cause. We have to look at each causes. The most important one being to rule out a nosocomial infection. Now, when they go home and they are well, and when they go home, especially after COVID, if they get a fever after 2 or 3 days, and it's a significant fever. When I say significant fever, more than 38.5 or at least more than 100.5 degrees Fahrenheit, 38.5 degrees centigrade, we need to be sure that they are not suffering with what we call as one of the long COVID problems, or a multisystemic inflammatory syndrome kind of a problem, which is seen in COVID. I think that's what we need to look at. We should be asking them to do some simple clinical examination by coming down to the hospital, perhaps repeat a CBC and CRP and see if the CRP is rapidly jumping up. We also need to realize that sometimes these patients actually may be brewing an infection, but once they have gone home, the infection has become florid, and that's what needs to be treated. So we need to make sure that they don't have any infection, do appropriate test based on a clinical examination so that you can find out what the cause for fever is. I think, sir, fever is a very interesting topic. Fever can be, if we just were to describe fever on our medical history taking, you could describe fever as low grade. People start with feeling of feverishness, low grade fever, high grade fever, unabating fever, fever which is not breaking down, fever which is or which has got some diurnal variations, evening rise of temperature, alternate day fever. There are so many types of fever we could look at, and I think fever is a topic on which, Professor Joshi, you could have a PhD student doing a thesis, and you would still have another couple to do more thesis on fever. So I think fever is a huge topic. It's not possible to cover in 40 minutes of talk, but I think we had a good round of questions from the audience and fantastic presentation by yourself. With that, I would like to just say my usual words. Stay safe. COVID is still in the air. It has not gone anywhere. Please, please, please wear a double mask. For frontline workers, please wear an N95 mask. When you're stepping out of the house, think twice. Do you really need to go out of the house? If yes, then take all of these precautions and go out of the house. Obviously, if you are working, you would need to step out. So please be very cautious about how you protect yourself and the others who are working around you. And if your vaccination is not complete, now is the time to go ahead and complete your vaccination. Whether it's your first dose, second dose, or if you're eligible for a precautionary additional dose, go ahead and take it. Sir, your last few words and we close down the program.
I think I completely agree with Dr. Rahul Panditji. We need to stay safe, behave responsibly, as he rightly said, mask appropriately and completely needed double mask, and ensure that we get our vaccinations on board. And if you have symptoms like cold or cough, isolate yourself, get a COVID test done. If you have fever, there's a red flag. It could be due to COVID, it could be due to non-COVID. Sort it out with your doctor, and your doctor will guide you and aid you in these difficult times. It's a matter of couple of weeks, and we will be tiding over this. And hopefully, let us hope and pray that with responsible behavior, we will be able to tame and start living our lives again in a COVID world. Thank you. Let's meet once again. I'm sure that you have the endless versions of Dr. KK's Med Talks. We all remember him fondly, and let us ensure that this 555 show has been useful, informative, educative. Our idea is to give direction and education. It is basically for information, education, and counseling. Every case needs it to be individualized. So there are no blanket statements for that, but we need to save every life. Our current goal with COVID is zero COVID deaths and have less severe cases. Thank you very much. And I'm sure that you will be meeting again, once again, for the 556 show tomorrow on the Dr. KK's Med Talks.
Thank you.